So before I get started, excuse me, on my head to toe assessment, I'm going to go over my SBAR report sheet. It's Miss Marilyn Hughes, as if I was giving a report to the nurse coming on shift. So Miss Marilyn Hughes, she's a 45-year-old female, full code patient of Dr. Reeves. She was admitted today with a left mid-shaft tib fib fracture when she slipped on icy steps at home. She was taken to surgery earlier today for an open reduction with internal fixation and arrived in recovery at 1:45. Vital signs: temp 99.1, pulse 96, respirations are 18 breaths a minute, blood pressure 138/88, O2 stats are 99% on room air. And when she originally came to the unit, she was complaining of pain 6 out of 10 to her left leg. She was given morphine, 6 milligrams IV at 2:15 for that complaint of pain. The patient has an IV in her right AC 18 gauge that is currently running lactated ringers at 75 cc's an hour. She's ANO times 4, person, place, time, and situation. She's non-weight bearing on her left leg, and she also has an order to elevate her left leg as tolerated. She's not on oxygen. Her breath sounds are clear in all lobes, no cough. Her peripheral pulses are palpable. However, her left pedal pulse is weak. She also has +3 non-pitting edema to her lower left leg. Her bowel sounds are active in all quads. Her last BM was earlier today. She is currently on a clear liquid diet. Advanced to regular is tolerated. Not complaining of any nausea. She is continent of bowel and bladder. However, she is bed rest because she's non-weight bearing on that left lower extremity, so she voids via bedpan. She is complaining of numbness and tingling to her left lower extremity, as well as showing weakness to her left lower extremity. She has island dressing with an ACE wrap to her left lower leg. And her relevant labs: her hemoglobin is slightly low at 12.5, and her hematocrit is 38, which is also slightly low. That's not really abnormal. She just came from surgery. It's possible that she lost a little blood during surgery, so we're going to continue to watch that. For the recommendations for the SBAR, I recommend that the patient go home with PT/OT via home health. Also follow up with ortho, who is the person the most likely to do the surgery, for further instructions on what to do after discharge. So I have the patient chart right here for Ms. Hughes. Which I will refer to during the assessment. Okay, so for my assessment, this is Miss Hughes. She's laying in the bed. Before I would enter the room, I would knock. Knock, 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 knock. She says to come in. I would immediately enter the room and perform hand hygiene. I would walk over to the patient, introduce myself. Hi, Miss Hughes. My name is Brittany. I'm going to be your nurse today. I'm just here to do a quick assessment on you and take a look at your leg. Is that all right with you? She says yes, it's fine with her. So, before I begin, I am going to verify her name and date of birth. Miss Hughes, can you please tell me your name and date of birth? Marilyn Hughes, 922XX. And Miss Hughes, do you have any allergies that I need to be aware of? Drug or food allergies? She says no. She has no allergies that she is aware of at this current time. I would grab gloves and all my all my necessary supplies, including vital sign machine, pulse ox, stethoscope, pen light, anything that I would need to do my assessment. I would clean everything beforehand using an alcohol wipe, and I would start off by doing assessment on this patient, ask her how she's feeling today, and Miss Hughes tells me she's feeling pretty good. She's having some pain, which I will assess further. I would start off getting her vital signs. And her vital signs are, vital signs are temp 99.1, heart rate 96, respiration rate 18, blood pressure 138/88, O2 is 99% on room air. Before I begin my assessment, I would close the door if it's a private room or draw the curtain. After obtaining her vital signs, I would start from the head and work my way to the feet, depending on what she's got going on. So the first thing I'm going to do is look at her eyes. Have my pen light, and I'm going to check her pupil reaction. Her pupils are equal, round, reactive to light and accommodation. Her sclerae are clear. Miss Hughes, do you have any hearing aids that I need to know about? Or do you have any difficulty hearing? She doesn't have any hearing aids. She doesn't have any difficulty hearing. What about glasses or contacts? Do you have any glasses or contacts? No, she doesn't have any glasses or contacts. So I'm just gonna overall look at her first, see that her color is good for her ethnicity, and she's not pale. Her skin is moist. I'm gonna look at her ears, make sure there's no drainage from her ears, and I don't see any drainage. I'm gonna look at her face, see if it's symmetrical, which it is. I'm gonna look up her nose to see if she's having any bleeding or any type of drainage whatsoever. I'm gonna ask her to open her mouth. Miss Hughes, can you open your mouth for me, please, so I can take a look? So upon inspection, the mucous membranes are moist. She has her natural teeth, so she doesn't wear any upper or lower dentures. I'm going to take a look at her neck. Everything looks symmetrical to me. I'm going to see if I feel any JVD or any swelling to her nodes, which she has none. I'm going to visually inspect the chest underneath the breasts for any type of yeast rash or scars or anything of that sort. I'm going to then, since I'm on the chest, listen to her, where's my stethoscope? Listen to her lung sounds and her heart. Okay. While I'm up here, I'm going to go ahead and listen to her heart as well, since it's in the same region. Okay. The heart, sinus rhythm. I'm going to listen also to her lungs back here. Okay. All right, Miss Hughes. And are you eating okay? Do you have any issues with swallowing? She says no. She's currently eating fine. She is currently on a thin liquid diet, but she has been tolerating that without any nausea nausea or vomiting. After I assess her lungs, I also am going to assess if she has a cough, which she does not. Her lungs are clear. No evidence of wheezing or rales or anything like that. So after I assess that, I'm going to just take a look at her fingertips. I'm going to check her cap refill, comparing it to the other side, and she has cap refill less than 3 seconds on her right and left upper extremity. I'm also going to take a look at her hands, check her skin turgor. I'm also going to assess her strength. So I'm going to have her squeeze my hands at the same time to see if there's any weakness in either of those extremities, which she doesn't have any weakness in her upper extremity. She's squeezing my hand just fine. I'm also going to feel for the radial pulse while I'm here. And both of the radial pulses in the upper extremities are strong. I'm going to have her hold out her arms like this with her eyes closed and see if she can hold them there, which she can. She's also going to need to push against my hands to further assess that strength, which her strength is equal on both sides. She's also going to pull up like this at the same time to further assess the strength. I'm going to look underneath her arms, make sure there's no rashes back there. I'm going to assess the abdomen, look at it first, see if there's any distension that I notice, anything abnormal, any scars, old C-section scars, stuff like that. I don't see anything. So I am then going to listen to her bowel sounds. Okay. Her bowel sounds are active. Miss Hughes told me that she had a BM today. It was normal for her, not complaining of any constipation, any diarrhea, anything like that. She is passing gas after her surgery. She has not yet had a BM after the surgery, so we'll need to continue to watch that, but the bowel sounds are active. I'm asking her if she's having any pain in her stomach or her chest. She denies any chest pain. She denies any stomach pain, so I'm going to go ahead and palpate. So I'm going to just lightly palpate her abdomen to feel if there's any distension or if she has any rebound pain, which she does not. She's not complaining of any pain to either area. She is urinating fine. She is continent of bowel and bladder. She says that she is able to use the bedpan because this patient is non-weight bearing on her left lower extremity. She's currently not getting up. Rehab has not had a chance to work with her yet, so we are currently using the bedpan for her. Her urinary is normal, straw-colored urine, urinating fine. So I'm going to go ahead and head down towards the legs. Before I do that, I'm going to flip her over and I'm going to look at her sacrum to see if there's any moisture associated skin damage or pressure areas or anything that I need to be aware of, anything at all on the back. Stay. Okay. She currently has a left wrap, a left ace wrap to her left lower extremity. It is on pillows because she's tolerating that's just fine. She did tell me upon assessment earlier that she is having pain, 8 out of 10, when I assessed her, and that is unusual for her because an hour ago she was complaining of 6 out of 10 pain and she had a morphine dose. So it's only been an hour. She's complaining of 8 out of 10 pain to this left lower extremity. So we're going to assess that. First, I'm just going to visually look at the extremities, make sure they look the same on both sides. I did note that she is having increased swelling to her left lower extremity and her left foot. It does also appear that she has some pallor to her left side compared to her right. So what I'm going to go ahead and do is unwrap that left extremity, lower extremity, to further assess it. So I'm unwrapping it. She has moderate drainage to her incision site. She is having +3 non-pitting edema to her left lower foot and extremity. I am going to assess her pulses, her peripheral pulses. I can assess the popliteal first, which is located behind the knee, sort of, with 2 fingers, and comparing it to both sides. She is having a weak peripheral pulse on the left side. So I'm going to go ahead and move down the leg and feel her dorsalis pedis pulse, which is located on the top of the foot, and I'm also comparing that to the other side. She does still have a weak pulse to her left lower extremity. Right is strong, right is normal, no pallor, no swelling. I'm going to go ahead and check her cap refill. Cap refill is less than 3 seconds on the right hand side, but that left leg that she had surgery on, it's greater than 3 seconds. As I stated before, it has pallor, so it's kind of pale. I'm going to assess her strength. So I'm going to place my hands on top of her feet and ask her to pull them back. And I notice that she is having weakness to that left side as well compared to the right. I'm also going to place my hands underneath her feet here and have her push, which I also note weakness that way. I'm going to ask her if she's having any numbness or tingling to her extremities, upper or lower. She complains of numbness and tingling to her left lower extremity only. I'm going to touch her feet and ask if she can feel me. and she can feel me touching her feet. She is not complaining of any calf tenderness, other than the pain in her left lower leg anyways. But right side, no calf tenderness, no swelling. So, based on my assessment, I am going to call the doctor because Miss Hughes is having increased pain to her left lower extremity. 8 out of a 10, which was an hour ago, 6 out of a 10, and she received pain medicine, so that's kind of abnormal. She also is having the increased swelling, the pallor, the numbness and tingling, the delayed cap refill, all in that left lower extremity. So before I leave the patient, I already unwrapped her left lower leg and removed it off of the pillows. So I'm gonna give the patient the call bell, bed in lowest position. I'm going to explain to her that, Miss Hughes, I need to call the doctor because of everything that I found during my assessment, and I'm gonna have the doctor come and take a look at you when, as soon as he can. So here's your call light. If you need anything, please don't hesitate to call me, and I'll be right back. So Miss Hughes is hanging out in the bed. I am going to call the doctor, get my patient chart. Again, her patient of Dr. Reeves. So, hi, Dr. Reeves. This is Brittany. I'm calling from the ortho floor in reference to Miss Marilyn Hughes. Date of birth is 9/22/XX. She was admitted to us for a left mid-shaft tib-fib fracture with an open reduction with internal fixation that was performed today. She currently is having some issues with that left lower extremity. She is complaining of increased pain. She currently is on morphine 4 to 6 milligrams, IV push every 4 hours, and she received a 6 milligram dose an hour ago. She was originally complaining of pain 6 out of 10, and now her pain has increased to an 8 out of a 10. She's having +3 non-pinning edema to her left lower extremity, as well as pallor, decreased sensation, delayed cap refill. Her vital signs: temp 99.1, respirations 18, blood pressure 138/88, heart rate 96, and she's 99% on room air. She did have labs drawn. Okay, and her labs showed that her hemoglobin is 12.5, when originally before surgery it was a 14, and her hematocrit is a 38, and originally it was a 41. Everything else is within normal limits. I have removed her ACE bandages from her left lower extremity. I removed her left lower extremity off the pillows, but I'm very concerned about compartment syndrome with this patient. So it would be very much appreciated if you could please come to the floor as soon as possible to assess that left leg. Dr. Reeves said that he will be to the unit within 15 minutes to see the patient. So I thank him for his time. I will go back into the room and check on Miss Hughes. She's not complaining of any increased pain. I'm also going to reassess that leg. Even though I just did it a few minutes ago, compartment syndrome can move very quickly. So I just want to make sure nothing has changed. So I will reassess that leg. It's about the same. She hasn't had anything extra going on. Her pain is still an 8 out of a 10. Unfortunately, it's too early for me to give her any more morphine. So when the doctor comes and assesses the patient, if he wants to write new orders for an increased dose or a stat dose of morphine for this patient, since she's currently on a clear liquid diet, I also would not upgrade her diet at this time, only because it's a possibility that this patient could go back to surgery if compartment syndrome is expected. So I don't want to jump ahead of the game and put her on a regular diet and then her have to go back to surgery. While I'm in there, I'm going to go ahead and take a look at her IV fluids, make sure that they match what I currently have on my MAR, which is lactated ringers, infusing at 75 cc's an hour. I'm also going to check that her IV is patent, that she's not having any redness, swelling, anything at that IV site, which I didn't notice during my assessment earlier. I'm going to put bed in lowest position when I leave the room, call light within reach. And I think that's it. Okay. Miss Hughes was a very good patient, and yeah, thank you.